You can start your presentation, sir. Uh, so it will give us an immense pleasure to introduce Dr. Satvik Khattar, who is medical oncologist, DM medical oncologist from Tata Memorial Hospital, associated with Apollo Hospital Indore, and who is having more than 10 years of experience into oncology setup. And today, Dr. Satvik is going to share valuable perspective on the darolutamide in management of MHSPC. So, Dr. Satvik, welcome you, and you can start, sir, your presentation now.
Okay, I'll just share the screen.
Yeah.
Just a second. Yeah. Uh, just a minute. Okay. Okay. So
Yes, sir, it's visible.
it's full screen.
Yeah, it's full screen, sir.
Yeah. So
So,
good evening, everyone.
yeah.
And thank you, Bayer, for giving me this opportunity. I'll be going to talk briefly about the role of darolutamide as a benchmark in metastatic HSPC setting as a single agent. The trial which we are going to discuss is an ARANODE trial, and this is a new benchmark in metastatic HSPC therapy. We have been using, as personally used darolutamide with docetaxel based on the Essence trial, but now we have a study where even single agent darolutamide has shown remarkable results in metastatic HSPC. So these slides are prepared for scientific and educational purposes by Bayer, and I have not modified these slides. So the standard of care in metastatic HSPC, as we know, has evolved immensely, starting with pre-2014 only ADT, either medical or surgical castration. Then started with docetaxel with ADT in Charter trial in 2014. Then in 15, Stampede, which was a multi-arm trial where again docetaxel results were published in 2015, where essentially these two trials established docetaxel as the standard of care in metastatic HSPC setting in combination with ADT. But then came two trials for abiraterone. There was a Stampede arm G where they showed abiraterone showed benefit as compared to ADT, as well as Latitude came a year earlier in 2017 where abiraterone again was compared with ADT alone, and these two landmark trials then established abiraterone as the standard of care. So these four trials, and we used to study all these trials in during our DM training, also Charted, Stampede, and Latitude, which essentially paved the way and consolidated the standard of care in form of docetaxel or abiraterone along with ADT. So ADT alone was essentially reserved for very frail, elderly, not fit for any other therapies. Otherwise, the standard of care for a routine metastatic HSPC became either docetaxel or abiraterone along with ADT. Then in 2019, the RGs, that is the enzalutamide with ADT, Enzamet, enzalutamide plus ADT plus minus docetaxel came. At the same time, apalutamide came into the picture with Titan trial, where they showed benefit. All these trials showed significant clinical benefit in their primary endpoints as compared to ADT alone. So by 2019-20, we had in numerous agents to combine with ADT, be it enzalutamide, abiraterone, docetaxel, apalutamide. Then by 2021, triplets started coming in with a Peace One trial, which is a landmark trial, abiraterone with ADT with docetaxel. Plus minus, in fact, radiation, also local radiation to low volume metastatic disease. So basically, triplet then became standard of care for fit PS1, PS0 patients, fit patients. Triplet became the standard of care in metastatic HSPC setting with the remarkable OS results. But despite treatment with androgen receptor pathway inhibitors, ADT or docetaxel, a large proportion of patients with metastatic HSPC progress to metastatic CRPC within 3 years. So all of these agents have a disease control of somewhere around 2 years, 2.5 years, up to 3 years. So then by 2022, Addison's trial came where darolutamide, again a triplet regimen, where darolutamide with ADT with docetaxel results were shown, and we have now used this in since quite few years, and we know the significant drop in PSA, the clinical benefit which patients receive immediately, as well as the progression-free survival and overall survival which we are seeing in our day-to-day clinical practice. Then in 2024, Arano trial, which we are going to discuss in this today's PPT, where darolutamide in combination with ADT versus ADT was tried, and there was again a trial RSEC, where again a second trial for darolutamide. So an unmet medical need remains for an efficacious treatment that offers a differentiated and improved safety profile for patients with metastatic HSPC without adding significant toxicities and with a low drug-drug interaction potential. So we know docetaxel has its own limitations. It has toxicities like peripheral edema, it has peripheral neuropathy, there is febrile neutropenia, there is significant fatigue, there is skin rash, skin lesions, alopecia. So there are a lot of toxicities with regards to docetaxel. When it comes to abiraterone, then we have other side effects like raised diabetes, raised sugar levels in diabetic patients. Hypertension is one worrisome factor. Pedal edema is one. So patients who already have a cardiovascular comorbidity, so abiraterone cannot be given safely in those patients. So these enzalutamide has its CNS side effects. So all these drugs have some or the other limiting factor. And we know with metastatic HSPC patients surviving for years altogether, these toxicities, although rare, they do become significant when we are giving these patients these therapies for long, and these patients are surviving for longer. So talking about the Addison's trial, where darolutamide was tried with docetaxel with ADT, it was a phase 3 study, and it has already showed beneficial efficacy and safety profile in HSPC setting, and it was approved in India in 2023 as a triplet combination in HSPC. Darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in HSPC setting in Arano trial with significant, and this trial had significant Indian patients. And with this data, darolutamide has the potential to change the treatment paradigm, as now it would be the only ARI which could be used with as well as without chemotherapy safely. So in Addison's trial, darolutamide with ADT with docetaxel demonstrated favorable efficacy and safety versus the doublet of docetaxel and ADT in patients with metastatic HSPC. And Arano was designed to evaluate darolutamide with ADT, plus ADT versus ADT to provide a new treatment option for patients of metastatic HSPC who do not wish to have chemotherapy as their treatment of choice in the HSPC setting. So talking about the study design, this was a randomized double-blind placebo-controlled phase 3 study, and it was a double-blind until primary analysis, and until final analysis, it was an open-label trial. So total 665 patients were enrolled, and they had to be adenocarcinoma of the prostate. The rare variants were excluded. The PS important point that up to PS2 patients were taken, which usually these are patients where we do not prefer chemotherapy. So again, being an oral therapy, PS2 patients are eligible for this drug, and the patients were stratified based on visceral metastasis, whether it was present or absent, and prior local therapy any received or not. And this was a 2:1 randomization where patients were randomized into darolutamide 600 mg BD arm versus placebo, and obviously ADT was the base was common in both the arms as a standard of care. The primary endpoint was radiological PFS. The secondary endpoints OS was the key secondary endpoint. Time to initiation of subsequent antineoplastic therapy, time to CRPC, time to PSA progression, rate of undetectable PSA, time to PSA. So basically, the standard endpoints which we see in HSPC setting in all the prostate cancer trials. There were some other pre-specified endpoints like PFS2, time to skeletal events, time to deterioration of the quality of life, FACT-P, time to first prostate cancer-related invasive procedure. And the metastatic disease was confirmed by conventional imaging. This is very important because nowadays we are routinely doing PSMA PET, but all these trials, because they were planned very early, Then at that time, bone scan or CT scan or MRI used to be routinely we used to do for staging assessment. So post primary analysis, then it became open label, and there was 100% crossover to open label darolutamide in the placebo arm, and the selected endpoints in the final analysis were OS and the safety. And the data cutoff taken was 7th June 2024. The median follow-up was close to 2 years, 25.3 months in the darolutamide group and 25 months in the placebo group. Talking about the patient characteristics, the baseline characteristics, the median age was 17, both the arms. You can see the wide range from 43 to 93 years, almost similar in both the arms. So a wide range of age range was taken. Uh, Asian patients were 30, close to 30% patients were Asian. This is very important in this trial. And the performance status, 0 was 52% and 1 to 2 was 47%. 70% patients had Gleason score 8 or more. So basically a high prognostic group patients. The metastatic, de novo metastatic patients were 70% in the darolutamide and 75% in the placebo group. And recurrent patients were 20 to 22%. 70% patients had high volume disease. Again, this is very, very important because nowadays we in high volume metastatic disease, we try to give triplet therapy, but there are patients who are not fit for triplet therapy. Then we end up giving doublet, and we think that this is a suboptimal treatment. But it's not like that, because even in this doublet trial, there were 70% patients were high volume patients. Uh, Somewhere around 12% patients had visceral metastasis. Majority did not have any visceral metastasis, which we also very commonly see that 90% of the patients do not present with visceral metastasis in HSPC setting. So you can see the difference, because why this is important for India, for us, because if you see the other trials, India was not even a center. But in Aeronaut trial, India was a major center among other countries. So a good proportion of patients were from India. So you can see 61 patients were from India, 65 from China. So quite similar presentation inclusion when it comes to, if compared to China. Then there was 15 from Taiwan, Australia, 21 New Zealand, 10. So a good proportion of patients were from India in this trial. Talking about the primary endpoint, darolutamide plus ADT significantly reduced the risk of radiological progression or death by 46% versus placebo. The hazard ratio was 0.54. And you can see at 2-year cutoff, the radiological PFS was 70.3% in the darolutamide arm, and median was not reached, versus 52.1% in the placebo arm, with a median PFS of 25 months. So this is very, very important, that 70% of the patients, 2 out of 3 patients, did not progress even after 2 years in the darolutamide arm. And this benefit was consistent across the subgroups, irrespective of the age, irrespective of the baseline PSA value, irrespective of the performance status. Again, very important. Irrespective of the disease volume, the point which I was making in the baseline slide, that even with high volume metastatic disease, patients did benefit as compared to ADT alone. So if a PS2 patient, where we are unable to give triplet therapy, so a doublet is not suboptimal regimen, and we should and many old timers, or you might be seeing urologists prescribing only ADT. But we have to make this point that only ADT is inferior. Even in PS2 patients, we should give hormonal therapy, androgen receptor and pathway inhibitors, because they do benefit and they have a very good safety profile, even in this setting. Benefit, if we talk about other secondary endpoints, overall survival, although the data is still immature, patients will be followed for survival, and hopefully we'll be discussing about overall survival in future. And important point that all remaining per protocol placebo patients were offered crossover to darolutamide after primary analysis. So it will be very interesting to see the whether we get any OS benefit in the long run. And darolutamide plus ADT delayed the time to CRPC and time to pain progression. You can see time to metastatic CRPC, the median time is not reached in the darolutamide arm versus it is 13.8 months in the placebo plus ADT arm with a hazard ratio of 0.4. Talking about time to pain progression, it was not reached in darolutamide arm versus 29.9 months in the placebo arm. So the darolutamide delays the time to pain progression, and this is very, very important clinically because this is a very important clinical endpoint, time to pain, because this is the most common complaint when patients progresses clinically, and this is something which has not been demonstrated with other androgen receptor pathway inhibitors till date. Talking about the durable and deep responses, PSA less than 0.2, that is which is considered as undetectable level at any time during treatment, which was 60% of the 62.6, in fact, absolutely in absolute value, 62.6% of the patients achieved undetectable PSA as compared to only 18.5% of the patients in the placebo arm. And talking about time to PSA progression, it was not reached in the darolutamide arm versus 16.8 months in the placebo arm. So again, this is very, very significant and very important endpoint. A higher proportion of patients achieved in darolutamide arm. Just a second. So patients achieving, if we talk about the divide into subgroup high volume versus low volume, a higher proportion of patients achieved undetectable PSA with darolutamide, irrespective of the volume of the disease. Subsequent anti-cancer therapy, patients with subsequent life-prolonging systemic anti-neoplastic therapy, 32% of the patients in the darolutamide arm received some form of therapy. Majority of them received docetaxel, some received abiraterone, and then some received enzalutamide, cabazitaxel, or radium. In placebo arm, 42% of the patients received some kind of systemic therapy. Majority of them received again docetaxel, some received abiraterone, some received enzalutamide. Talking about the treatment emergent adverse events, it was similar between treatment groups, and discontinuations were lower in the darolutamide arm. So any kind of adverse event was seen in 90% in both the arms, where if you talk about grade 3 or 4 adverse events, it was again comparable, 30% in both the arm. Grade 5 events were also, in fact, that is death due to treatment, were also similar in both the arms. So, but the treatment discontinuation due to adverse events was lower in the darolutamide arm, 6% versus 9% in the placebo arm. And the safety profile of darolutamide in this trial was independent of the PSA response and consistent with the favorable tolerability as seen in the RMS and RFS trial. Talking about the most common adverse events, they were low and similar between the treatment arms: anemia, arthralgias, UTIs, back pain, transaminitis, increase pain in extremities. So majority of them were mild. If you see grade 3 or 4, they were very, very less, 3%, 2%, 1%. So we know that it's a fairly well tolerated drug. And the adverse events which occurred in 5% or more of the patients: hypertension, bone pain, weight gain, fatigue, hyperglycemia. But again, if you talk about grade 3, 4, you can see hardly 4%, 2%, and in fact less than 1%. So it is very, very important that we have to counsel the patients. You can have these side effects, but they are usually very mild, and hardly that is 4 or 5%. There is 4 or 5% chance that you will get a serious side effect. And the rates of adverse events commonly associated with androgen receptor pathway inhibitors was similar across the treatment arm, be it hypertension, vasodilation, and arrhythmias, fatigue, rash. It was comparable in both the arms. Talking about the health-related quality of life, so darolutamide extended the median time to deterioration in the FACT-P total score by 5.1 months versus placebo. And it is the first and only androgen receptor pathway inhibitor to demonstrate clinically meaningful delays in the pain progression and overall well-being. So the time to deterioration in FACT-P total score in darolutamide arm was 16.6 months versus 11.5 months in the placebo arm. Talking about the quality of life, the social or family well-being, functional well-being, emotional well-being, urinary symptoms, bowel symptoms, all of them favor darolutamide as compared to placebo. So to conclude, darolutamide plus ADT significantly improved radiological PFS in patients with metastatic HSPC, and it showed us benefit across all secondary endpoints. It was associated with a deeper PSA response regardless of the baseline PSA, and it is the first and only androgen receptor pathway inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social and family well-being, functional well-being, urinary symptoms, and it has a favorable safety profile. So darolutamide plus AT without docetaxel should become an additional standard of care. It is not the only standard of care. I think, yeah, it's very well written that it is an additional standard of care for metastatic HSBC, and this can be very safely given even in patients who refuse triplet therapy despite being fit. We see patients who say that no, we don't want chemotherapy at all, so we end up giving doublet androgen receptor pathway inhibitor, and darolutamide is a very good choice, I would say, seeing the results. So this was all in brief, and thank you for the patient listening.
Thank you, doctor. Deepak, any question is there?
No question, officially.
Okay. So as there is no question, sir, thank you. Thanks for your time and sharing the insights on Aeronaut trial in doublet regime in the management of MHSPC. Thank you, sir, once again on behalf of darolutamide oncology team from BRT. Thank you, sir. Have a good night.
Thank you so much. Good.
So I request technical team to close the session. Okay, sir. So should I close the session?
Yeah, please.
Go ahead. Okay. Thank you.